Hi, guys. Welcome back to Hope Unscripted, a podcast for Hope Cancer Resources. I'm your co-host, Brittany Harmon, along with
Jamie Dietrich.
And today we are going to be focusing on nutrition education with Ms. Erin Moore, who is a registered dietitian for Highlands Oncology.
Thank you. Thank you for having me.
Yes, we're excited to have you here. So this is going to be a 2-part series. So don't give up after part 1 because it's going to be really good because part 2 will be coming. So Erin, we want to learn a little bit more about Erin without the registered dietitian part, and then we'll kind of dive into that and your career, and we'll just take it from there. So just tell us a little bit about you.
Well, I was born and raised in Arkansas, went to the University of Arkansas, went to UAMS for grad school, found my way back to Northwest Arkansas, and I've been here about 13 years with my husband and my family.
Awesome. How many kids do you have?
I've got 2 boys.
Okay.
My husband coaches football, so I'm the odd man out here.
Big Razorback fans?
Yes, big Razorback fans. My husband actually played and coached for the U of A.
Wow.
So, yes, we love Razorback football.
Okay. My husband, too. He works for the Razorbacks, so I hear about it all the time. It never stops.
Nice, too. So a lot of our guests have been, we call them transplants around here that have come from not around Northwest Arkansas. So you might be one of our first ones that's born and raised over here.
Yeah.
So what path led you to become a registered dietitian, and then how did that lead you into oncology?
Yeah, I started taking a nutrition course probably my junior year of high school. My small town actually offered a course in, I guess, the basic science of nutrition as well as food science, kind of in combination with some sort of home ec lab where you do experiments with food science. And so I started taking home books and just became interested in it. And I had a friend whose mom was a dietitian. And so I kind of knew what dietitians did. But I kind of just made my mind up. I love science. I love math. I love helping people. And so I decided I would major in dietetics and did that and went to grad school at UAMS and did my internship, became board certified, licensed dietitian. And what's ironic is I thought I would never want to work in a hospital or with really, really sick people. I thought I wanted to do more wellness and nutrition education, and I ended up doing the exact opposite of that.
And that's how life works.
Yes, I ended up falling in love with critical care and ended up doing that, both adults and neonates, for over a decade, and ended up being board certified to specialize in enteral and parenteral nutrition, which is feeding through veins and tubes. So far, far, far from what I had originally planned. I also had a big interest in sports nutrition as my husband's a coach and thought that was going to be my future, and just took a turn when I got into clinicals. But those skills and my specialty with tube feedings, especially, and a little bit with what we call TPN or IV nutrition, being board certified in that and being a specialist managing that type of nutrition has led me directly into oncology, because when I came on board here at Highlands, I started seeing patients with really high acuity, high nutrition needs, mostly the ones who couldn't swallow because of the type of cancer they had or the treatment or the surgery. So I see a lot of head and neck cancer, esophageal cancer. And so I manage their feedings and their nutrition through their feeding tube. So I didn't know that that would lead me here, but it has, and it's all fallen into place. And I love being able to help those patients who can't eat and drink like they normally would.
I think about that. Personally, I have a story. My grandfather had esophageal cancer. He passed away several years ago, unfortunately, but I remember him having a tube because of that, and then the feeding tube on top of that. For a long time, he would still chew food, spit it out because he could still taste it for a while, but then it gets to the point that you can't anymore. And it was hard. It was difficult. I was 16 at the time, and I couldn't be in the room when they were doing the tube feeding because I'm not the one to watch that. So yeah, so I can appreciate somebody that's a special gift to have and be able to do that for people.
Thank you.
I always think it's interesting hearing someone's path to how they become what they are today. And I started off in college, thought I wanted to be a lawyer, and then it was something else. I don't know, and then something else. And then I ended up getting my degree in science in dietetics. And I didn't go on and do my master's because at the time you couldn't work, and I already lived on my own and all the things. And so it's funny now sitting here today, I work for a nonprofit. So path just leads you in an interesting direction sometimes. So you're clearly very passionate about where you have ended up. And so is all the nutrition that you do you do some that's like more basic nutrition of like if someone is not on a feeding tube or an IV?
Yeah, of course. People don't usually go from, eating to drastically not eating, not able to take anything by mouth. Mm-hmm. Sometimes or a lot of the time it's gradual as a side effect of treatment or the disease, or maybe it's just temporarily after a surgery. And then, of course, there's a continuum where patients start out eating, and I help them maximize getting enough hydration, nutrition, until they absolutely can't support their needs, taking everything in by mouth. And then we gradually start to use their feeding tube. And then on the back end of treatment, or when they're ready, it kind of goes in reverse, where we see them be able to eat and drink again. And as they do that more, we get to kind of wean off of their feedings through the tube and eventually get the tube out for a lot of the patients. And that's a really exciting time for them as well.
I can imagine for sure. So what does your day-to-day look like at Highlands right now? Like when you're in the clinics, do you deal with patients on a daily basis?
Yeah, every day I have a clinic load, and every day is different. I end up at all the different clinics, just like the other providers. Between Fayetteville, Springdale, Rogers. Some of the days it looks like seeing patients in radiation who come every day for radiation treatment for a series of weeks. And so I might be seeing them weekly to touch base and see if they're having any side effects that affect eating, drinking, appetite, nausea. Sometimes they are coming to our infusion room for some sort of treatment, whether it's chemo, immunotherapy, or just IV fluids. And I meet them there every week, every month, however often. A lot of times I will see patients in the exam rooms in conjunction with the other providers, like the physicians, the speech therapists sometimes, and we collaborate just because our roles overlap in a transdisciplinary way, where we're all collectively kind of managing side effects of treatment and symptoms. And so it's a very seamless process where we're able to help the patient collectively. And then there's a couple days a week where I am in what we call our multidisciplinary clinic, and we have providers come in from outside of Highlands. So we have surgeons come from UAMS, ENT of the Ozarks, Mercy, for our head and neck surgery patients. We have, on our chest clinic day, we have thoracic surgeons come for our lung cancer and esophageal patients. And we have our pulmonologists come as well. And so we're all collectively seeing new patients or follow-ups together. Mm-hmm. And on those days, we have a multidisciplinary tumor board where we discuss these cases and what the best plan of care is for their treatment. So every day looks very different.
Oh, busy all the time.
In a different location. And then we also have our clinic in Mountain Home. And I help those patients remotely as best I can. There aren't a whole lot of resources in that area. And to my knowledge, they don't have access to a dietitian outside of the hospital system. Mm-hmm. And so I, along with another part-time dietitian, help support them remotely. We sometimes will do telemedicine visits or phone calls to follow up and check in on them. Of course, they're Highlands patients, so we can still see all of their labs, their treatment plan, their vital signs, the notes from other providers. And so everything other than being able to physically see them and touch them in person to examine them. Yeah. So kind of a lot of different things, a lot of different ways. But yeah. It involves a lot.
So busy. That is way more broad than I expected it to be, honestly. Like, I had no idea. So that's incredible.
Yeah.
Erin,
So
do you have a team under you? Are you the only RD? Or?
So I started out as a solo dietitian, and so my focus was fairly narrow, trying to get to the patients with the highest need that aren't able to receive the care they need anywhere else, which is the feeding tube patients mainly. And then about a year ago, we added a part-time dietitian. Okay. And we are looking to continue to expand. As our clinic has expanded, our providers have increased. The area has grown. So yes, we are growing.
It feels like you need a whole like troop of people, like minimum 20.
Well, and that, kind of leads into what I do is kind of the high acuity, urgent need, new diagnosis, going through treatment, or had a sudden change and need help. But ideally, it would be a goal of mine to be able to provide preventative care and education, as well as survivorship education. As it is, we do provide education to patients specific to their diagnosis, and then they all each individually have their own medical history and individualized needs. And so, whether they've had multiple surgeries in the past, that all feed into it. But we try to provide them education on risk factors related to their cancer. How do we prevent disease recurrence? How do we prevent the disease from worsening from a nutrition, diet, and lifestyle perspective? Or it may just be, how do we manage metabolically and keep their labs at a normal range so that they can, coast through their treatment with as minimal side effects as possible.
Is there any kind of a patient story that has impacted you that you would like to share? I mean, obviously we don't say names or anything like that, but I feel like every time we speak to somebody that's been in the clinic, or even with our people at Hope Cancer Resources, there's always that one story that just hits you. So,
gosh, there's numerous stories. There's too many to name. I will say that collectively, I see a large population of middle to older age men. And a lot of people have a premonition or stigma around feeding tubes. And they associate them with end of life or ill children or some sort of special needs diagnosis. And they don't realize that there are many other applications. But once they are diagnosed and learn that they're going to need an alternate route of hydration, nutrition. And once we work together and they get through the treatment, a lot of times I hear feedback that, wow, I had no idea. I didn't realize this is what it was like. I didn't realize nutrition played a huge role. I didn't realize you did anything besides tell people what not to eat. I was waiting for that one. A lot of them come in and say, are you just going to tell me what I did wrong, or that I can't eat, or I can't have my coffee or my favorite whatever? And they're usually very happy to learn that there's not a whole lot of anything I will tell anyone they can't have unless it causes harm. So that's always exciting.
So funny.
So the other thing is, I have quite a few patients who don't receive a lot of medical care up until the point of their cancer diagnosis, haven't really been exposed to much of healthcare and seen a lot of doctors in the past. And when they get into this, they have minimal resources. And so a huge part of what I do relies on Hope Cancer Resources. I joke that I'm the dealer for the care closet because when my patients need tube feeding mainly, or any of the supplies related to just taking care of their tube, a lot of times they may not have insurance, or they may not have insurance yet, or they've got insurance. I've, set them up with a referral to get all these supplies at home, but it's not going to be there yet.
It takes forever.
And they have a sudden impact from their treatment and went from, okay, my throat was a little bit sore, I was a little bit nauseous, to suddenly I haven't been able to keep anything down, or I can't swallow. I've got to do something now. And so having the care closet and the donated resources for feeding tubes is just a huge blessing. I couldn't help the majority of my patients without it.
Oh, thank you
and
for sharing that.
It fills a major gap, and it's really nice to see whenever someone finishes using their tube, they get it removed, they say, I have all of this extra stuff that I've never touched, and I would hate to throw it away. I'd hate for it to go to waste, and they can donate it to the care closet. And I've even had several patients who see the full circle.
Yeah.
They relied on the care closet in the beginning to get them started, and then they're able to give back when they're done. And so it feels good for them to be able to help out as well.
I think it's such a beautiful circle to see someone benefit from it, but then be able to give back to it. It's something that we're really starting to put a lot of focus into. Not that we didn't intentionally before, but we're trying to see how we can grow that and how we can help more people through the closet. So thank you for sharing that. That makes me feel really good.
And I'm saying that I've seen a patient drop off stuff and excited to drop it off and get it out of her house at that point. She was so excited to get rid of what she didn't need anymore and got to walk it back in there and see the full scope. So that was really cool too. So that's amazing.
So a patient comes and they've been diagnosed with cancer. So what part of the journey is it once they're in treatment, or is it referral from a doctor, or how do they end up in your care?
Usually they have come through the multidisciplinary clinic referral process. So as I mentioned, patients with esophageal cancer or head and neck cancers come through our multidisciplinary clinic. And so they're set up with a list of providers that are going to need to see the patient, and the patient is going to require some sort of evaluation or ongoing care from these disciplines. And so I'm usually automatically plugged in with those patients as they are very high nutrition risk. They often come to me already malnourished or undernourished, or if they're not already in a deficit, they need lots of education on what's to come. And so that's how a lot of my patients end up on my caseload. Also, any physician seeing a patient that identifies a need, obviously, as one person, I can't meet all of their needs. And so I try my best to provide education one-on-one and materials that I can give to them, mail to them if they're, remotely at a different clinic. But providers do also make referrals.
Okay. And that's all within Highlands, right? So,
I know do you ever get referrals to somebody who has a diagnosis it's not necessarily head and neck, that may not need a feeding tube or IV?
Yeah.
And what does that look like?
Other patients in oncology, most patients should receive some sort of nutrition education. And a lot of them do need a dietitian. They need at least evaluated up front so that if their condition deteriorates, they're able to receive some follow-up and adjustment to their care. But other patients that have really high nutrition needs within the oncology population are those who have tumors or cancers of the GI tract. So it could be colorectal cancer, hepatobiliary cancers, gastric cancer. There's just so many. And then there's the cancers that you wouldn't think relate to eating, but the treatment itself is so harsh that it causes side effects that really deteriorate nutrition.
Yeah.
So working with those patients often looks like, what are your side effects? How can we manipulate things to where you're still able to eat and drink even though you're nauseous, or even though you may have zero appetite or zero taste, or you may be sleeping a lot, or your schedule might look different, or maybe you're unable to shop and prepare the normal foods that you do. How do we work around that?
That makes sense. Yeah.
Okay, Erin, tell us a little bit about the patients who go out and Google and kind of do some of their own research, and then they come to you, and how do you navigate that and just kind of help bring them into, I'm going to say reality, because we all knew Google, ChatGPT, all the things can be a little out there.
Yeah. There is a plethora of information on the internet, and
Some misinformation, some ways too. Yep.
with social media as well. Yeah, I'm guilty as well. I love a good rabbit hole. So I love to learn. I love to see what's out there. And as well with social media, there's lots of actual providers out there giving information. And so, of course, it's natural for someone to be curious and want to find out as much as they can, so that when they do meet with their care team, that they feel prepared and have the right questions and want to know if what they've heard of is offered here and whatnot. And one thing that patients feel they could easily control is what they put in their body, whether they cared about that up until their diagnosis or not. Suddenly it's something they can control. And so often they're looking for, what supplement or what food can I consume that kills cancer, or that fights cancer, or that prevents it? What should I not eat if I have cancer? And so that leads to a lot of misinformation. It leads to a lot of confusing and conflicting information. And so it really depends. If I have someone who's kind of done their research and looked, sometimes it may be something brand new that I've never heard of, and that's not uncommon because things are constantly evolving and changing. They're constantly coming out with new products, new research. And so I always do my best to try and look into whatever it is if I'm not familiar, and give them an educated answer.
Yeah.
Obviously, as providers, we try to be ethical and provide, science-based, evidence-based information, but not everything's black and white. So we also try to meet a patient where they are. If their belief is that they don't want to do a certain type of treatment that's recommended to them, but they'll do part of it, then, it's their decision. And so we meet them where they're at, and we help them make an educated decision. We give them the information that we have on safety and risk and things like that. When it comes to nutrition, a lot of patients want to take high-dose vitamins that are known to have antioxidant properties that kill free radicals, or supposedly out there to kill cancer cells. And so sometimes we will provide education on what we do know, or we will say, we don't have enough education on that. We don't know if it's harmful. We don't know if it interferes with your treatment. So we really can't say. The best thing we can offer is it's probably best not to do that right now, but maybe when you're done with treatment, as an adjunct. Or maybe we say, we know this one competes with your chemo drug or your radiation to fight and kill this type of cancer. So we wouldn't want for you to get the full effect of treatment. We don't want anything to interfere. And so we recommend that you hold off on that for now. And they may or may not take the advice, but we're still going to support them through everything else, no matter if we agree on that or not.
Yeah. That's a really hard thing.
That is. And I've always been told this, and I don't know if it's actually accurate or not, but you can take as much vitamin C, you take a bunch, your body's only going to absorb so much though. Yeah. Then it's just going to get rid of what it can absorb. So I feel like it gets to the point, if you just overload yourself, you probably are causing a little more harm than good and just not realizing it, or just wasting a lot of money on supplements running right through you.
Yes. And what a lot of people don't realize is, nutrition, it's not just what you eat. And so there are many pharmacological aspects of it, including supplements. So when I mentioned those pathways, that vitamin C, for example, there is, some literature that vitamin C in very high doses, not your typical supplement doses or what's in a multivitamin, can potentially compete with or interfere with certain types of treatment. And so those are the instances where we say, in general, when you overconsume a certain nutrient, that your body doesn't have stores of, it will flush it out. You will have extensive urine, as they say.
Yeah.
But there's other cases where it can have that pharmacokinetic interaction with actual medication.
That's interesting.
And so it goes well beyond, what is this nutrient? What does it do?
Mm-hmm.
And then you add 10 of them to the picture, and you're having to cross-reference and look at everything and figure out, okay, what do we know is safe, and what do we not know anything about, and decide how to move forward.
So we've got a few minutes left, and I want to shift gears just a little bit. I'm going to do kind of myth versus fact with you, and then we're going to do a rapid fire.
Okay.
So we're going to have a little fun with this. So some of the common myths, I'm just going to say them, and then you can give the nod.
I'll totally debunk a little bit.
Yeah, let's debunk it a little bit. So sugar feeds cancer.
Yes, I hear this one a lot. I think there's a misconception there just because of a couple different reasons. One, a diet high in refined sugar or excess sugar leads to inflammation, which then leads to an environment where diseases like chronic diseases and cancer can develop. So that's one piece of it.
Mm-hmm.
The other piece is often when they describe having a PET scan, they tell you that you're going to take radio-tagged, contrast that takes up sugar rapidly. And cancer is a metabolically active process. And so that's why we see the cancer light up on the screen, but we also see the brain and the bladder light up, and that's not cancer. And so I think some people just take away from that, oh, cancer eats up the sugar, cancer lights up with the radio-tagged sugar feeds cancer.
Yeah, interesting.
And, sugar may feed cancer in a petri dish, but our body is much more complex.
I hope so.
Our body is much more complex in a very different environment than a petri dish with only those two elements. So,
okay. So you should only eat organic foods and fruits and vegetables.
Yeah. Organic is a tough one. Any sort of term that's marketed, that's FDA approved for labeling is very tough. And it's often confusing to consumers. And sometimes, we could have a full-time job just dispelling myths or misconceptions related to these labels. Ultimately, it comes down to what someone's individual goals are. If, they don't know where their food's coming from and they're very fearful of pesticides or additives, or if they are hooked on thinking that's exactly what caused their cancer, or they just grasp onto it as something they control, then they may want to try to eat all organic. It's not financially feasible for most people.
Right.
And we don't have a whole lot of backing to say only eat organic. But, with cancer, your immune system is depressed or suppressed. And so we harp on washing fruits and vegetables really well. If it's too suppressed, then we avoid instances where even fresh fruits and vegetables and washing them might pose a risk, not just of pesticides, but of, any sort of bacteria that can make them ill. So it's really a personal preference. Doesn't make them any more nutritious, that's for sure.
Well, and I'll get on soapbox just a little bit about the marketing behind it, because if you, like you said, you have to actually know where it's coming from, because there's a lot of rules and loopholes to be able to market something as organic when it might not actually be. And so I think that people need to focus more on the education behind that too. I'm in the BI industry, and so me and my husband have cattle, and we understand, like, just because it's slapped a sticker on there does not really mean you know exactly where it came from. So
and that's definitely not my forte, but I've sat through several lectures from dietitians and other people in the ag industry, and organic is not the same across the board, or it doesn't mean there weren't pesticides used, and it can become very complex.
A lot of loopholes for sure. What about alkaline diets fighting cancer?
There's not a whole lot of weight there. Again, with alkaline, it basically means that you're in more of a basic environment versus acidic when we're looking at acids, bases. Our kidneys and our body has a process of maintaining homeostasis. Our lungs play a role in that. When I worked in critical care, we were trying to balance acid-base disorders constantly. And that was through, different methods. But, for someone who is outside the hospital setting, drinking alkaline water isn't going to make their blood or their GI tract alkaline because, for example, our blood has several liters and is constantly pumping through our kidneys and other organs and being filtered. And so it gets diluted.
Yeah.
Same with the GI tract. You make several liters of fluid throughout your GI tract during the day. So if it truly were a way to make your, body more alkaline environment, then eating something like a tomato, which is very acidic, would put us in an acidotic environment. And it just simply doesn't work that way.
Gotcha.
So
I just feel like that's one that it just doesn't make a lot of sense. I mean, just to say I'm going to do an alkaline diet, but then you go do the research or try to do the research, like it just doesn't make sense.
And everybody has their personal preferences, and if that's what you want to do, go for it for sure.
and
it doesn't work for everybody,
right. And that was speaking more to just like the alkaline waters and things, but to truly do an alkaline diet, I mean, it would require so much control and from person to person without doing it under direct supervision, like in a research trial. And then there's just so many other factors based on everyone having individualized healthcare issues, medications. I just don't know that it's something that is truly controllable.
Yeah, that makes sense.
Okay, rapid fire. Are you ready?
Yes.
Okay. Which one is better, coffee or tea?
Tea.
Okay. Favorite healthy snack?
Any fruit.
Any fruit? Okay. Most overrated nutrition trend?
Oh, gosh.
That's a hard one, isn't it?
I would probably say keto.
Oh, okay. Interesting. Most underrated food?
Beans.
All
I can
beans?
totally see that. Yeah.
Legumes.
Okay. One nutrition habit everyone could improve?
Fiber.
Oh, yeah.
Through natural foods or through supplement?
Natural.
Okay. One thing you wish people would stop believing?
Just one.
The one you wish you most. Yeah.
Sugar feeds cancer. Sugar causes cancer.
Okay.
Look
Put that.
Yeah.
All right, Erin, thank you for joining us. This is episode 1 of 2. We will be back with Erin on another episode, and Brittany's going to close us out.
Thank you guys so much for listening in today. If you have any questions or want to reach out, just contact us at hopecancerresources.org. And like Jamie said, we'll be back with Erin in part 2. Bye.
Bye.